Now we are going to have only one part to talk about. That is the treatment of Cushing syndrome. Right? So let's all of us begin this. Treatment of Cushing's. Okay, and this is very simple for all of you. If you have understood till now, then it is going to be very easy for you. So for example, the most common cause of Cushing syndrome is the exogenous, right? And how to treat the exogenous Cushing syndrome? Stop the drug. But keep in mind, in the theory it seems very easy thing, stop the drug. But don't forget, the doctor is prescribing the patient steroid is not just for having fun, isn't it? The patient is taking this steroid for some particular reason. There must be something, maybe some rheumatic diseases in the body, rheumatoid arthritis, let's say, or the SLE or any disease, or the patient is having some situation in which, for example, asthma, where we need to give the steroid, sometimes we need to go to the high dose steroid. So theoretically, stopping the drug is going to treat the exogenous, but it is not going to be that simple. Sometimes we need to find the way. So keep in mind, suppose, all of you imagine this thing, if a person is having, let's say, rheumatoid arthritis, you are giving the patient steroid, patient is doing fine. Right, and now patient develop the Cushing syndrome. So now your aim is to decrease the steroid. So we use one particular terminology. We call it steroid sparing agents. Steroid sparing agents, and those are the example of the DMA, RDs. All of you remember, the lots of drugs we had, the azathioprine, the methotrexate. So we can even instill those drugs, and we may try to decrease the dose of steroid, or sometimes we can even stop the steroid. So we can even use the drugs which we call them steroid sparing drugs. Clear? Okay. So in the exogenous, just stop the medication. Okay, now let's go further. If the patient is having endogenous, and this endogenous is due to Cushing's disease, right? Cushing's disease means the patient is having pituitary adenoma. So the best treatment for this person is going to be the surgery, and this surgery we call it transsphenoidal, right? Transsphenoidal surgery of the pituitary gland. So we call it transsphenoidal surgery. In some patients, when we cannot perform the surgery, when the surgery is not surgery is contraindicated, then we can use some somatostatin analogs. For example, the pasireotides. So pasireotides. What is pasireotide? It is the somatostatin analog, right? But never forget, if somebody asks you what is the best treatment for the Cushing disease, what is your answer? Transsphenoidal surgery. The best is the surgery. Remove it. But if the surgery is not successful, or let's say that surgery cannot be done for this patient, then we are going to choose for the drug therapy, and the drug therapy is going to be the pasireotide, right? It is simply one of the example of somatostatin analog. Clear what I'm saying? Okay, now in the same way, let's go for a third one. Suppose that patient got the adrenal cancer or adrenal pathology. Maybe the patient is having adrenal cancer or adrenal adenoma or the bilateral adrenal hyperplasia. Again, if I ask you, what is the best treatment for this patient? Surgical removal. Surgical removal of the both adrenal gland or the involved adrenal gland? Involved. If the adenoma is in one side, so only that one will be removed. But if it is the bilateral hyperplasia of the adrenal gland, then we must give the bilateral removal, right? So it is simply going to be again surgical removal. Surgical removal. And if the surgical removal cannot be done, then there is one drug, we call it mitotane. All of you write this down. Mitotane. This drug mitotane is also sometimes used. What is the mitotane? This drug is having two jobs. Number one, it can kill the adrenal cancerous cell. Right. Another one, it is anti-steroidogenesis. Means if this drug we give to the patient, the steroid synthesis will be decreased. What idea? It means the adrenal gland will not be able to produce the cortisol, will not be able to produce any kind of steroid. So this is the example of anti-steroidogenesis. At the same time, I told you that this drug also can have some anti-adrenal cell activity. Anti-adrenal cell activity. So in this way, I want people to remember this drug's name very well. This is they have started asking you. So mitoten is very commonly being asked in the exams, right? So mitoten have got two way of action. What is the first one? Anti-estroidogenesis. It will not let the adrenal gland to produce steroids. And number two, it is also having some function of anti-adrenal cell activity. So some of the cancerous cell or the adenomatous cell, these cells can be damaged by this drug, right? What is the name of the drug? Mitoten. Now the same way, suppose that if the patient is having the problem in the ectopic paraneoplastic ACTH, then what was the treatment for this one? Tell me. Paraneoplastic ACTH, what was the treatment? It depends upon what is causing it. If it is a small cell lung cancer, then maybe the chemotherapy will be very good response, right? So it depends upon what is causing it. What idea? If it is a thyroid medullary cancer, then best treatment is to remove the thyroid gland. Thyroidectomy is the best treatment. If it is a small cell lung cancer, then the best treatment is the chemotherapy. So it depends upon what is producing the ectopic ACTH, and the treatment can be done on that basis. Got idea? And now at the same time, I want people to know one more thing here. Make one note of this thing. This drug, mifepristone, in the gynecology obstetrics, we must have learned this drug in very much detail. Mifepristone, right? Mifepristone is also one of the oral therapeutic, the drug stimulating the. Where you have studied the mifepristone? Have you studied it or not? So mifepristone is one of the very commonly used drug for the abortion, right? The drug abortion, drug-induced abortion, mifepristone. All good idea. So this mifepristone have one very, very important function. This mifepristone is going to cause the cortisol. It will decrease the cortisol sensitivity to our cells. Every cell in our body. So what will happen, that if somebody is having high amount of cortisol, and if we are not able to do this treatment, then we can even prescribe the mifepristone. And this mifepristone, while prescribing, you have to be careful. You have to know the situation when you cannot prescribe this drug. And then when you prescribe, how does it work? It's simply going to decrease the cortisol sensitivity in our tissues. So although there is a high amount of cortisol, but these tissues will not respond to the amount of cortisol, right? So it is going to simply decrease the cortisol sensitivity by inhibiting the cortisol receptor of our body. Clear what is saying? Okay, now let me tell you the last concept of our class today, that is called as Nelson syndrome. Have you heard the name? Nelson's syndrome. Nelson syndrome. Yeah, this is the last one. So what is Nelson syndrome? All of you try to imagine this thing. Suppose a patient came to you and he is having the Cushing syndrome due to the adrenal pathology, right? This patient is having Cushing syndrome due to adrenal pathology. So what is the best treatment for this patient? The removal of the adrenal gland. So you remove the adrenal gland. Imagine this thing. We as a doctor, we remove the adrenal gland. So now in this axis, hypothalamus, pituitary and the adrenal axis, now we have removed one part. We have removed the adrenal gland. So if there is no cortisol in the body, and we are giving this, after removing the adrenal gland, we are giving some external glucocorticoid as a treatment. So if the cortisol is not present, then there is a negative feedback in the pituitary gland. Is the negative feedback in the hypothalamus? No. So hypothalamus will keep on producing more and more CRH, and the pituitary gland is going to produce more and more ACTH. And this ACTH has nothing to work upon. There is no adrenal gland. So this pituitary gland, due to the lack of negative feedback, will start increasing in size, right? And this pituitary gland sometimes will develop the adenoma, and it will become so bigger that patient will have the mass occupying lesion in the brain and can have some situation, and this situation I have given a name. What do you call it? Nelson syndrome. Once again, let me repeat. This happens after, this syndrome develops after we perform bilateral what? Adrenalectomy. So suppose that this patient came to you, he was having this adrenal pathology, and you removed his both adrenal gland. And once you both adrenal gland is removed, then in the hypothalamus pituitary adrenal axis, now there is no adrenal gland, so there is no negative feedback to your hypothalamus by the cortisol, there is no negative feedback to your pituitary by the cortisol, and due to which the pituitary will produce more and more ACTH or less ACTH? More ACTH, and this ACTH again is not having any negative feedback. So pituitary will try to produce more and more ACTH, more and more ACTH, and slowly pituitary gland will become very large, right? So it is going to cause enlargement of pituitary gland. Sometimes it can even lead to the pituitary adenoma. Now the pituitary gland become very big. Now, as soon as the pituitary gland will become very big, there are few features going to happen, and those are the features of Nelson syndrome. You tell me, if the pituitary gland becomes very big, can it compress the chiasma or not, optic chiasma? Yes, and whenever the optic chiasma is compressed, then patient will not be able to see the temporal side, right? So both the temporal side, if we have to look at the vision, so this is the normal vision, suppose that this is the nose here, so this is the nasal vision and this is the temporal vision. And you know that the central part is the one that crosses the side. All of you know this thing, isn't it? And this is the part of chiasma. So if this area is going to be blocked, right, then the temporal vision, you can see that if this area is going to be obstructed by the pituitary tumor, then this medial retina, the nasal retina, is having some problem. And you can know that if the nasal retina is having the problem, it means the image will not be formed from which side? Temporal side. So nasal retina is having the problem, it means we will not be able to see the temporal side, right? So this area will not be able to see, and this area will not be able to see because the nasal retina has been damaged. Let's say nasal retina is not able to give the information to your primary visual cortex. Is this concept clear? So this patient may develop the bitemporal hemianopia because of compression of the chiasma. Bitemporal hemianopia, and let me just draw one picture of bitemporal hemianopia. The bitemporal hemianopia looks something like this. If this is the image, in this image, this is the nose here. So the temporal side you are not able to see. So we call it bitemporal hemianopia, right? Hemianopia means half hemi, and bitemporal means both side temporal image is not there. Keep in mind, temporal image is not there means which retina is having the problem? Nasal retina. If I have to draw one eye, never forget this thing. If this is your eye, then this retina gets the light from this side and this retina gets the light from other side. So this is just the opposite, right? So if the patient is having the temporal image problem, it means the patient is going to have the problem in the nasal retina. Okay, this is the one. Second thing, if there is very big tumor in the head, adenoma in the head, then patient is going to develop what? Headache. Sometimes they may even have the sign and symptom of the increased intracranial pressure. For example, there may be the vomiting also, projectile vomiting, right? So there may be headache or features of increased intracranial pressure. All these features can happen in this person. And the very important thing that you should not forget, you tell me, if the pituitary gland is producing more and more ACTH, what is the precursor for ACTH? POMC, right? So there will be increased amount of POMC. Give me the full form of POMC. Pro-opio-melanocortin. And if this is very high, right? If this is very high, not only the ACTH is high, also one hormone will be also high. Which one? MSH, and this is going to cause what? Hyperpigmentation. Clear about this thing? It is going to also cause the hyperpigmentation. So these are the features about Nelson syndrome, and I have found that these days in the exam, from the Cushing syndrome, they are very much caring about the Nelson syndrome. That what is Nelson syndrome? So few things to remember. Nelson syndrome happens once we perform the bilateral adrenalectomy. Nelson syndrome happens because there is very high amount of ACTH, and due to which there will be enlargement of the pituitary gland, and that is going to these three very important features. Number one, the patient will have the bitemporal hemianopia. Patient will have a headache and the feature of the increased intracranial pressure, and patient is going to have the high amount of POMC, having high amount of MSH, having the hyperpigmentation in the body, and this is all about the Cushing syndrome. Right, so any question from our class today? Okay, then we go back home.